Okay. All right. Okay. Thank you. All right. So his pain is over the right shoulder here. Okay. This is it. Anterolateral, supra-anterolateral shoulder. Okay. That's my complaint. I've had it for, actually, I'll give you a bit more. I've had it for 3 weeks. I woke up with an ache in the shoulder, the general area of the shoulder, about 3 weeks ago. It improved, it was almost gone. And then I was making my bed and tucking the sheet underneath. I got a sharp pain there, and that was a week ago, and that's what I've got. It's not there all the time, but it comes on when I'm doing odds and ends, and there's no consistency to it. I can be lifting something up, I can try and put my hand in the pocket. There's no real consistency, it'll just grab me. Okay?
Okay.
All right.
How high does your pain typically get to?
I would say that it's a sharp pain. It's not disabling. I hate doing numbers. You want me to give you a number?
No, that's fine.
All
Does
right.
it bother you like reaching overhead?
Now and then, not always. It's inconsistent. I would say that I get this pain about probably at least 5 or 6 times a day, and it was sharp pain, and then it's gone.
Does it bother you when you reach across your body?
It's inconsistent. I've stopped paying attention to it.
Okay.
No, I don't think it's that so much. I think it's, yeah, I really don't know.
And what, can you remind me again what the original, like when this originally started bothering you?
About 3 weeks ago, I woke up this making.
Is there anything you did the day before out of the
No,
ordinary?
no. And it actually can wake me up at night. I can get a sharp pain every now and then, and it wakes me up. I don't know when it doesn't wake me up, but I do know when it does.
When you wake up at night, are you in a certain position?
No, not
Like, is that consistent?
Not that I can think of.
Okay. What is palpation like?
No, you can't do that.
Joint?
You're going to tell me the test you're doing, and I'll tell you the results of them. So you need to tell me what you, what structure, over what area are you palpating? If you like, what structure?
Yeah. So, what's the palpation of like the AC joint?
Negative.
Okay. What about the biceps tendon?
That's tender.
Okay. Anything on the like anterior shoulder joint line?
Palpation of the area? No, it's not particularly tender.
Okay. What's the like biceps tone, resting biceps tone feel like?
The tone of the biceps? Not particularly remarkable.
What's active range of motion of the shoulder look like, specifically with flexion?
Well, elevation? Elevation or flexion?
Elevation.
Okay. Tell me how you're testing it.
What'd you say?
How are you testing it? Are you grabbing the arm, just yarding it up? What are you doing?
Actively, I would just have them lift their arms straight
Active?
overhead. As far, yeah.
No, that looks reasonable. Looks full range.
Okay. Any pain? Like, what about passively?
Passively, again, tell me how you're doing it.
So I'd have them supine, and then if they're not eliciting any pain at end range, I would do overpressures.
What are you stabilizing anything, or are you just lifting the arm right up?
Stabilizing the scapula. And taking the humerus
if you're doing it right, there's a slight limitation at the end of elevation, and with the overpressure, that's a little painful. And actually, that's the same with elevation when you do it. The arm is painful on overpressure. elevation. That's when the patient does it actively and you do it afterwards.
What is the biceps strength testing in a lengthened position? So shoulder extended, elbow flexion. What is that? Does that reproduce pain?
No.
Okay. What about like a speeds test?
I really don't know what that is. Describe it to me.
So resisted shoulder flexion through, I'd take them. I actually would just test them in with shoulder flexion in neutral, extended, and then also like in shoulder, like probably 90 degrees of shoulder elevation. Are there any differences there?
So you're testing again though, are you testing elevation of the shoulder or are you testing flexion of the elbow when you do this?
Elevation of the shoulder.
Okay, no, that's negative.
How is the cervical spine range of motion specifically with, is it right? You said right shoulder? With right
I'm going to
rotation.
put you up for a minute here. Why are you going to the cervical spine?
Looking for possible etiologies. I'm kind of sitting.
Hang on then, because I'm going to stop you. I'm going to stop you right now.
Okay.
Etiology of what?
Like, are you looking for my diagnosis?
What is your diagnosis? You can't look for an etiology without knowing what you're looking for.
Yep, I'm working with like a proximal biceps tendinosis.
And your contractile tests are negative. But your contractile tests are negative. Tell me what positives you got here.
What did you say?
Tell me the positives that you have here.
So biceps tenderness.
Yeah.
You said active range of motion elevation was slightly painful.
No, I said when you overpressed elevation.
With path.
Yeah, so you had him lift his arms up and that was negative. When you overpressed it, you notice there's slight limitation of movement and it's painful. So that's one positive. You also got a positive when you tested shoulder elevation, trying to stabilize the scapula. So there's your positive. You've got limited elevation and you've got tenderness over the biceps tendon. Is that enough to diagnose biceps tendinosis?
No, just because contractile tissues were negative.
Also, it wouldn't limit elevation, would it?
Yep.
So where are you?
What's the joint mobility for the glenohumeral joint look like?
Posterior gliding is restricted. The jammed end fit with it.
Okay. So then I'd probably work under but wouldn't that be more like an etiology or no?
It's up to you. I don't know. I'm waiting for a diagnosis from you.
Yeah.
What can limit shoulder elevation? If you think about it, what can limit shoulder elevation? Maybe humeral elevation, actually, because you stabilize the scapula. What can limit humeral elevation? What structure?
So you could have like an AC joint dysfunction. You could have.
You've already ruled the AC joint out by testing it. Not tender.
Yep. Like obviously glenohumeral motion.
Well, that's what's limited, yeah. So what can limit it?
You could have like a thoracic spine could be influencing that as well.
How? But you stabilized the scapula, you elevated the glenohumeral joint, and it was limited. How does the thoracic spine get involved with that?
Yeah, I'm back on etiologies. So you could have tightness with like the subscap, pec minor.
You tested the glide. The glide was limited. That says it's a joint, doesn't it?
Yeah. So like if you had a pathomechanical dysfunction at the glenohumeral joint.
Okay. So what would cause that? I mean, this is a nice flat joint. The labrum's almost plane. So how do you get this happening there? And it's happening from a neutral position as well. So what structure could do that?
The labrum?
Yeah.
So is there any laxity in the labrum?
Well, it's going to have to be an inclusion. There's going to have to be a labral inclusion blocking the joint movement.
Yeah.
So do you want to test the labrum?
I feel like I don't need to, knowing that it's already in a sublux position. You can just assume that it would be.
Oh, I see. Why would you do that when you don't have to assume it, where you can test it? Why would you assume it? There's no rush here. I mean, this guy's not going to die because he's bleeding out or anything. Why wouldn't you test this?
I don't know. I would test it.
Well, go ahead.
All right. What information does that give me?
Sorry, say again?
What information does the labral testing give me?
Well, it'll tell you whether the labrum's in trouble or not. You're assuming it now. I'm saying don't assume when you don't have to.
Okay, are you looking for like subjective questions for
No,
the labrum?
no, it's up to you. You're doing the test.
Yeah, so I want to test the labrum and see the integrity of the joint.
All right.
See if that's going to be a contributing factor or not.
So what are you going to do?
So I would do probably I do a biceps load to rule out like a possible slap lesion, and then a.
Okay, I'm not sure what that test is. You're talking about a load shift.
What about O'Brien's?
O'Brien's is positive.
Okay. For pain reproduction or
pain? Yeah, it doesn't do anything else. It's only a pain production test.
Okay.
If you want to mechanically test the labor, it's going to have to be a load shift test, and that's negative.
All right.
So you've got a positive O'Brien's, a negative load shift test, and a block joint.
So for a diagnosis, I guess that would lead to just like a degenerative labral tear, causing like a he says a loss of posterior glide.
Yeah, well, it's a loss of elevation. Yeah, and it's blocking posterior gliding. But can you explain to me the positive O'Brien's and the negative load shift?
The positive O'Brien's I'd expect.
That's straightforward. Yeah, you expect that. Yeah.
Yeah.
Did you expect the negative load shift?
The load shift, I think that could probably give you some mixed, just if it's already subluxed. I feel like that could.
Yeah, that's fair enough.
Give you like
it's already jammed. It's not going to shift. If you could shift it, it wouldn't be jammed anymore, would it?
Yeah.
Okay. All right. So you've got a labral tear, degenerative labral tear. Presumably, I mean, it's possible he's injured that in the past, but you've got a degenerative labral tear that's blocking joint movement. Why is the biceps tendon tender then?
It's going to affect the like length tension relationship and put more pressure on the proximal tendon.
Can you explain the length tension relationship to me?
Specifically the biceps, and we're saying that it's a anterior subluxation.
No, I'm not actually saying it's a subluxation. I'm saying that probably the labrum's included in the joint. I don't know if there's a misplacement of the head or not. My guess is it's probably not the head. Like the joint isn't capable of jamming up unless it dislocates. So it's likely that the labrum is included in the joint. The labrum's torn and it's included in the joint. It's an easy manipulation to do, but you can find that out. But let's assume that's what it is. We have a labral inclusion that you can manipulate it and make it better. My question is, why is the biceps tendon tender? And you said no tension relationship. I'm just asking you to explain to me what that is.
Yeah. So if it's jammed and if he's working like over like at end range, it's going to have to recruit more to make up from the pathomechanical block, and that's also going to change the axis of motion.
Is it at the end of range where it's working though? Is it working at the end of range?
Well, no, but I mean, no, because he's getting it all during, it sounds like more just like neutral position. So I'm going to work under the axis of motion is going to be off because if it's sublux, so it's going to cause.
That's my point now, isn't it? Is the axis off and is it subluxed?
Well, if it's got a pathomechanical block and it's
no, you can't do that.
Slide, I would assume.
No, the pathomechanical block is a model because we can't explain the subluxation. I'm saying to you that this is probably not subluxed. It's just like a meniscus tear in the knee. You don't say the knee's got a mechanical subluxation. You say that the meniscus is included. That's what I'm saying is probably what's happened here.
Okay, but wouldn't that still throw off the axis of motion because it's not going to have normal arthrokinematics?
No, it's not going to have normal arthrokinematics, but the problem is in elevation, isn't it? That's where you're picking up all the problems in elevation. The functional losses is anywhere. He's not sure. It's inconsistent. Yeah. My point is, though, is where is the tendon working where this very small change, this really small change in the length tension of this muscle is going to produce tenderness. In fact, I don't even want to know that. What I'm asking you is, why is it tender? I'm not even asking about that. What's happening in the tendon to make it in the tendon that it's tender? Let's tension relationship. All right. Why is it tender?
It's probably just getting more pressure on it.
Mm-hmm. Yeah, but what's happening inside the tendon? Is anything happening inside the tendon? Is there any pathology there?
We said no earlier.
I didn't say that. I just said your contractile tests were negative.
Yeah.
I didn't say there wasn't a problem with it. I just said your tests were negative.
Yeah.
If the rest of you are panicking, hang on a second. If the rest of you are panicking over this line of questioning, this is not you. Okay, it's at a somewhat different level. Right, so don't panic about this.
Yeah, I guess I'm not going to work under the I don't think that there would be a biceps pathology, because if you're looking from like a tendinosis or a tendonitis, there's not enough objective tests that are going to fit that. So I would say that there's no pathology, but I'm not 100% sure how I would rule in a pathology if it's not fitting like a tendinosis. Or
all right, I just want some possibilities. If that's the case, why is it tender to palpation? What will give you tenderness in tissue where there isn't a pathology as of yet?
inflammation. I don't know. Inflammation.
No, that's pathology. Segmental facilitation.
Yep.
Well, this could also be an incipient tendinosis.
Like
At some point or another, the tendon will get tender, but it's not going to show up in your contractile tests. So this could be an incipient tendinosis, or it could be segmental facilitation with hyperesthesia.
Okay.
All right.
Are you working under the? Are we working under segmental facilitation as like an etiology and not a diagnosis?
I'm just asking you. We're looking for explanation as to why it's tender. This is still this is still diagnostic, but you didn't explain why the biceps is tender. You can't just ignore it. It's a clinical finding. You've got to figure it out. Is this segmental facilitation, or is it an incipient tendinosis? This isn't etiology now. You're now trying to diagnose the biceps tendinosis, the biceps tenderness, rather.
Okay, so I would look at what's the resting tone of wrist like extensors?
Yeah, problem is I've already said there was no obvious tone changes, and that's very often the case with segmental facilitation. What you want to feel
that's where I'm getting.
You want to feel.
That's where I'm getting hung up with.
Yeah, you want to feel in the neck. You want to palpate the paravertebrals in the neck, not distal. The more distal you go, the less chance you've got picking up that hypertonicity. But even that doesn't prove it. What you can do is wobble something, probably the neck, but if you wobble the neck and then repalpate the tendon and it's much less tender, then you can turn around and say it's probably segmental facilitation. But if it is incipient tendinosis, why would he have it?
Can you ask that again?
Okay, if it is incipient tendinosis, all right, he's not showing up, it's not painful and function, it's not this, it's not that, it's just tender and it's waiting to get worse. Why would he have it?
I guess I'm not 100% sure. Outside of segmental facilitation, I'm blanking on.
Okay, what about stabilizing an unstable shoulder joint? It's going to be doing that, isn't it? If the humeral joint's unstable, it means that the stabilizing muscles overwork, or it can do. So that could easily be the problem. If it had gone on for a bit longer, it may have been the tendon that brought them into you rather than the labrum.
Okay, are we talking about the same patient?
Yeah.
Okay, I'm getting hung up then. Why? Are you saying that the biceps would cause the? Are we working? It's under it like it's a subluxation or no?
We're working on this being
unstable and the biceps is.
No, we're working on this being a hypomobile, being a humeral joint that can't elevate properly. We're talking about it being unstable. It's not elevating now because you've got an inclusion from the labrum. If the labrum is not included, now you've got an unstable shoulder, haven't you?
Yeah.
So you're seeing him at the point where it's painful because it's included. It wasn't painful before, but it's painful now. So what happens is the tendons overwork to try and stabilize it, or they can do. Or they can become hypotonic and weak because of reflex inhibition, and that will produce the same result. They're vulnerable. So this could either be segmental facilitation, or it could be an incipient tendinosis, and that could be caused either because it's overworking because of the unstable shoulder, or it's a reflex inhibition problem because of the unstable shoulder. Yeah.
Yep.
Okay. Treatment. Hannah, sorry, are you awake? What's your treatment?
I would manipulate the shoulder.
Yeah.
See, retest the tenderness and motion.
Yeah.
What is that?
And you want to retest. Actually, once you manipulate it, you want to retest O'Brien's and then retest the load shift test. And you expect the load shift
Okay.
to be positive at that point. And then you can start looking at your rehab and everything else. What happens
So after the go ahead. What were you saying?
Sorry, yeah, after the manipulation, retest the load shift.
Okay, what is that?
Because that's going to prove to you exactly what's happening.
Okay. And then what does that information give me?
Well, actually, it tells you that it does need stabilizing, it does need rehab. What you've got now is you're actually working on an assumption because half of the label tests are positive and the other one's negative. You're assuming because it's jammed up, that's why the load shift test was negative. But if the load shift test stayed negative after the manipulation, I mean, you asked for this one, now what? All right, you've increased the range of motion at the shoulder. The elevation pain is pretty much gone, but you have a negative load shift test. So what's wrong here?
I would assume that there'd be something in the glenohumeral joint that's like free floating that's blocking it. I don't know. Because a load shift to be negative is a
This is why you're an expert. You're supposed to be able to work your way through this. This is not for you guys, neither. All right. Not for you not to listen to it, but you won't get asked this.
Yeah, I'm not 100% sure. So if the load shift is negative, are you saying the load shift is still positive or negative after the manipulation?
It's never been positive, has it? It's never been positive.
No, it's not.
It could be this wasn't a label tear. The problem you've got now is you have to explain why the limitation of shoulder elevation was there. Isn't you? This could, if you've got a positive O'Brien's and negative load shift test, what else would give you a positive O'Brien's? Forget the limitation of movement now. This is your patient, all right? New patient, positive O'Brien's, negative load shift test. And it's got good movement. So we start from that point. So what could cause that other than a label tear? Because you haven't got enough information you haven't got enough to say that it's a label tear. What else would it be?
With a positive O'Brien's and a negative load shift.
Yeah.
You could have some biceps tendinopathy.
No, we haven't. You've done all the contractile tests. It's all negative. The tendon area is tender, but your contractile tests are negative. In fact, O'Brien's test is so positive that when you do this in medial rotation, in supination lateral rotation of the shoulder, it's completely non-painful. It's only painful in medial rotation pronation.
I would assume that you just would have like a small enough labral tear that you wouldn't pick it up with a load shift test.
Now you're getting caught up on the labrum. No, this could be a transverse ligament tear. Couldn't it? That's exactly what happens.
Yeah.
You sensitize the medial lateral lip of the bicipital groove by medially laterally rotating the arm, then you both string the tendon against it. One of them's going to be positive, the other one's not. And it's going to be tender in that area. Yeah?
Yeah.
Okay. All right, not bad. It's a bit deeper. What you need to do with what's happened here is figure out what I've done that you don't agree with, and my approach and what you don't agree with, and then self-criticize. If you can't find anything wrong with me, then there's something wrong with you. So you need to self-criticize and see what's going on there. But there's biases at play. You can't assume things, all right? That's one of the worst biases there. As soon as you start assuming things, you're going to end up screwed. These are difficult cases, all right? I had a conversation with my M9 group, and they said, how often do you see it? I said, not very often, but it doesn't matter. You're the expert. If you're seeing referrals from 10 other people, if I see it once a year from my practice, and 10 other people send you referrals, you're likely to see it 10 times a year. This isn't about typical cases, so you can't make assumptions, all right? It's a whole different level of analysis, basically. And assumptions don't really come into it. In the end, sometimes you end up going, I have no idea what the hell's going on. That's fine. You don't always know what's going on, and then that's when you start hitting things and seeing what happens. That's just suck it and see approach, but that's the last resort. Okay. You all right?
Sounds good. Thanks, Jim.
All right. Michelle, I want the etiology now. We've got and it's a labral tear with an inclusion. You've manipulated it, it's moving well. Load shift test is positive, O'Brien's is negative. And I think we can safely ignore the tendinopathy if it's one, or the if it's segmental facilitation, you can ignore the tendons as well. So this is where we're going now. I need the etiology for the labral tear. Again, I'm your patient. You can ask me questions, you can do tests on me, but I won't stop you if I don't need to, all right?
Okay. So in my mind, I would want to look at CT junction.
I don't care. Questions, tests, that's all I want to hear.
I'm just thinking out loud.
Well, don't do that, because a patient won't put up with it. They wonder what the hell you're doing.
I think Tanner asked about it a little bit, but what does range of motion of the cervical spine look like?
What is he, 40? He's got a little bit of limitations in right rotation and extension. That extension quadrant is a little painful and it's a little limited.
Okay. And then I would want to do just like palpation with like inspiration, expiration, check mobility of the upper thoracic spine, see how it's moving, if it's.
All right. Okay. What are you feeling? What are you palpating?
So I'm feeling like T1, T2, have them like inhale, exhale, see if I can feel just like the movement of like I have like my hands on transverse processor, like feel the movement of the ribs.
Oh, you're testing the ribs now?
Yes.
Okay. No, they're okay.
Okay. When he brings his arms into elevation and flexion, I want to kind of see the movement with that, see if as he brings his arms into flexion, do they like descend down. Is still hands on like T1 or kind of right at CT junction, just feeling for movement as he goes into flexion.
All right, there's movement going on.
Okay.
There's movement going on in both directions.
Okay.
What levels are you testing?
Like T1, T2.
Okay.
So if that's all feeling good, I want to kind of feel maybe for movement of the clavicle, making sure that it's not feeling jammed at all. That would potentially limit some of the emotion of the glenohumeral joint or alter that motion.
That's moving.
Okay. So with the segmental facilitation, do we determine at what muscles were affected with that? Was that the
No,
biceps?
you know nothing about it. We was arguing the case for facilitation, but I never said there was facilitation.
Okay. So we've tested this guy for a facilitation and it's negative.
Tell me how you're doing it.
So I would just kind of go down the chain and test for like velocity dependent weakness.
Okay, so you're strength testing any particular segments you're interested in?
So I want to look at maybe like C5, so look at like abduction, external rotation.
Okay. You're interested really in C5-6, aren't you?
Mm-hmm.
C5 and C6. You're testing these with the arms by the side?
For external rotation.
Okay. You've got braking weakness there.
Okay. For external rotation?
Yeah, let's just make sure we're talking the same thing. Tell me exactly what you're doing. The arms by the side, the elbows bent. Yeah.
Yes. So
Okay. Which way are you pushing it?
I'm pushing inward. He's
okay. So you're testing lateral rotators.
Yes.
Okay. Braking weakness.
Okay. What about biceps? Well, biceps is 5 and 6, but what is testing strength
sorry,
of biceps?
say that again.
Of biceps? Well, I'm assuming biceps is going to be probably braking weakness as well, but what would that show?
You're assuming again.
Yeah.
Why?
I figured it would probably be painful with the transverse humeral ligament.
No, that was a whole different thing. What you've got there is a labral inclusion.
Okay.
And basically, we've ended up with a biceps tendinous, which is either facilitation or it's an incipient tendinosis. All right.
Mm-hmm.
Either way, you can ignore it. If you're looking for facilitation, then test it. But biceps wasn't painful on contractile tests, so you can test it.
Okay. So what did it show with testing for strength for the biceps, like a velocity dependent? Yes, of biceps.
Braking weakness.
Okay. What about wrist extension?
Wrist extension's a little weak, not a lot, a little bit.
What kind of weakness?
Non-fatigable, non-braking.
Non-fatigable weakness. So braking weakness, not velocity dependent weakness?
No, it's non-braking, non-fatigable.
Okay. So getting down a little bit further, I guess you can test like C7, you can get into the triceps and
All
wrist
right,
flexors.
I'm gonna break you a little bit. We're gonna say
Okay.
C6 facilitation, all right?
Okay.
Okay.
So if I'm finding a C6 facilitation, I would go and wobble C6 and see if that and retest and see if that makes a difference.
Yes, it does. So it's facilitation.
Okay. So then I would go into more of an exam for the cervical spine.
Why the cervical spine?
If it's a C6 that's being facilitated, I want to
This could
check.
be coming from the wrist.
Yeah.
So why fixate on the cervical spine?
I'm just looking for a source of that facilitation.
Yeah, but you went straight to the cervical spine. Why?
I guess that was kind of my first instinct for as far as what would cause a facilitation with the shoulder as well.
Okay, let me ask you this. If you examine the cervical spine, you find a C5-6 biomechanical dysfunction on the right side. Is that causing the facilitation?
I'm sorry, can you repeat that?
You find a C5-6 biomechanical dysfunction on the right side. Is that causing the facilitation?
It can't it?
Okay, so if you find that, what do you do now?
So that's when I would. So, what did the biomechanical exam show?
It doesn't really matter. It's a biomechanical dysfunction. We'll say an extension subluxation, C5-6 on the right.
Okay, so if you go in and manipulate that, does that and then retest? Does that make a difference?
Well, you can. It should do if you've got facilitation. But
Right.
what does that do for you? You've now manipulated somebody's neck who may not need manipulating. Manipulating the neck should be a thing that you do when you have to, not to find out if it's, you shouldn't be really using it as a diagnostic thing, but it isn't even diagnostic. If you manipulate C5-6 and the facilitation goes away, does that mean that C5-6 was causing the facilitation?
I guess in my mind, yes.
No. The facilitation can be caused by anything innervated by C5-6. Neck, wrist, elbow. Yeah.
Okay.
Yeah. So if you manipulate the neck, it will get rid of facilitation, not by getting rid of the cause of the facilitation, but by mediating the facilitation. You're doing a wobble basically in the neck. So even if it gets rid of the thing, all you're doing is wobbling the neck. So you can't draw conclusions from that.
Okay.
So you need to know if the neck is painful. You know that already, but you also, you can't draw that sort of conclusion from that. You can't be that certain about it. Even if this is positive, all right, let's say that you've established that there is C5-6 facilitation, you've established it's coming from the neck. Now explain to me how that will screw up the labrum.
So if you have a facilitation going on, I would expect it to obviously cause tone changes with, the shoulder girdle, which can affect as far as like the movement pattern, and that can cause maybe some breakdown of that labrum.
Have you got a more direct cause of this than that? Again, you're assuming that's what's going to happen, and you're assuming the breakdown of the shoulder girdle is going to be in the direction that's going to screw the labrum up. So is there anything more direct than that?
That can break down the labrum.
Yeah.
Well, if you have a facilitation of the biceps, and that tone change wouldn't be kind of constantly pulling a little bit on that superior labrum?
No, it's not enough to do that. No, the obvious
Okay.
one is it produces weak rotator cuff muscles. The stabilizer of the shoulders get weak.
Mm-hmm.
That in itself might be enough.
Okay.
Okay, but that's the obvious cause of it. The more complicated you make this, the less likely it is to be true.
Mm-hmm.
Go for the obvious first. I'm also, how good are the screening tests that you did with the upper thoracic spine?
What was your question?
How good are those screening tests you did? Are they for you to say that the thoracic spine isn't involved?
I mean, if it didn't really reveal any movement loss with just like a general CT junction exam, then
Okay.
I'd be a little less likely to jump right
All
into
right. The
a more
first thing
thorough
is
exam.
feeling the vertebra moving during inspiration isn't a very sensitive test. You've got to have the right size patient, you've got to have the sensitivity to do it, and it's not the best way of doing it.
Mm-hmm.
You're looking at mechanical problems. You do mechanical tests, you do PAs,
Mm-hmm.
and you can look at reflex inhibition there. What those breathing tests don't do is tell you about hypermobility and instability.
Mm-hmm.
So any of those, and it's go down to 6 actually, don't stop at 1 and 2. The axis of motion for the shoulder is T3. So go down a bit further, anywhere in the upper thoracic spine could do it. But this could be an upper thoracic problem that's called braking weakness, secondary reflex inhibition of the shoulder muscles. And that can lead to the breakdown. So there's all sorts of stuff going on here. I think what you're doing is you're going for availability. But if you're looking to screen things out, the tests have to be really sensitive. And breathing tests are not that.
Okay.
Even for the ribs area, if you just push on them and see if they're moving. But those breathing tests won't tell you about hypermobility and instability, both of which will cause either facilitation or reflex inhibition or both.
Mm-hmm.
Okay, so what's your screening tests? They've got to be good. They've got to be good enough for you to say, okay, we can throw that out.
Mm-hmm. Okay.
Okay, it's always possible, of course, that the etiology could have been, as I said earlier, an old injury.
Mm-hmm.
So there's your question for the patient. You're looking at it subjectively. Have you ever had a major injury to your shoulder? What happened? How long did it take to get better, and so on? Could he have torn the labrum earlier? If all of this is negative, what you got then possibly is axoplasmic flow problems, slow flow problems causing malnutrition. So now you want to know if there's a fast flow problem. So you're looking for fatigable weakness in these muscles. And then it's not a matter of assuming now, you can be pretty damn sure that if there's a fast flow problem, there's a slow flow, and that's all you're left with is a slow flow problem. Anyway, you have a fast flow problem that you can treat at least.
Mm-hmm.
Okay.
Okay, sounds good.
All right, same thing as with Tanner. Okay, figure out what you don't like about what I said. And if you can't find very much fault with it, then start looking at the way you're approaching these problems. All right. There's a lot of pressure here.
I'm sweating a lot here, Jim.
Yeah, I'm sure. These basically you're looking at an expert exam. This isn't like level 3 again. This is level 4. This is M9 stuff. This is much more advanced than the level 3 stuff. Okay. All right, let me throw this open. Any questions from anybody about any of that?
I have a question on the segmental facilitation stuff.
Okay.
So when you were saying before, when she was asking to look at cervical spine, and then asking what to do. So when you know that there's a segmental facilitation, are we still looking throughout the segment to see what
could be causing
is
it?
contributing?
What's causing actually? Don't forget, he's got a shoulder problem. So the chance of him not having a facilitated segment is really low. He's got shoulder pain. It's been there for 3 weeks. So there's a good chance he's got some degree of facilitation there anyway. Yeah. Now, the only way, if facilitation is caused by prolonged nociceptive input, you have to find out if the patient has joints that are nociceptive. That means producing pain. So in the neck, for example, you put them into that quadrant and you pull them back into it and you see if that's painful. There's one potential source. You look at the shoulder, you know that's painful. You don't have to do anything with that at all. You look at the elbow, do the quadrant testing on the elbow, do quadrant tests on the wrist. See if these are nociceptive, in which case they could be doing it. And then they're worth a look biomechanically. Okay, but you don't stop at the first one you find. And because wobbling helps, it doesn't mean to say that the thing you wobbled is causing. I should be able to wobble, technically, I should be able to wobble the middle finger and reduce C7 facilitation. I should be able to wobble the thumb and get rid of C6. Yeah, so if I wobble the neck, I can't be sure that the neck is the cause of the facilitation. Because all you're doing is you put in extra proprioceptive input, which mediates facilitation and, of course, reflex inhibition.
Okay, so then determining the source is just based on the nociceptive joint within.
Yeah, that's basically it. You don't even know if that's true. What you do then is you deal with the biomechanics on each of these joints. So you try and get rid of the nociceptive. If you really want to get, actually you don't. What you do is you assume now, regardless of what else you're finding, rather than spreading this all out, is you treat the joint that they come in with and you see what that does to the facilitation. It should reduce or eliminate the facilitation. And then as you treat the neck, the painful joint, if that stays non-nociceptive, then that facilitation should stay away. But you've also got to say, okay, well, the facilitation is causing the problem, or is actually contributing to the problem, or is a partial cause. And so it's not enough to find facilitation. You have to be able to link the facilitation with the problem the patients come in with. Yeah?
Yeah, that makes sense.
Anybody else? Was that fun watching people being tortured?
Your call as soon as they come in.
I'm not talking to Tanner and Michelle, because I know damn well it's not fun to have it done yet. But the rest of you, did you enjoy it?
Someone asked for a quick summary of fast flow and slow flow and antegrade and retrograde.
No, you don't. Retrograde, it really isn't our big problem with retrograde. I mean, it may play a role in trophic malnutrition, but the ones we're really interested in are synaptic vesicle replacements with fast flow and trophic nutrition with slow flow. The rest of it is really doesn't bother us too much. It bothers me so little, I don't even know the names of these bloody proteins that go in them. But they're all metabolites going retrograde. It may well contribute to swelling in the nerves, actually, because they've done this with disc herniations. On either side of the disc herniation, there is swelling on the nerve. So you got antegrade getting blocked by the disc herniation, retrograde is being blocked, and you get this congestion at both sides of the disc herniation. They cut the disc and then the flow goes down. So it's not going to help matters. And I don't think it's got a direct importance for us. I don't think.
Would you be catching and locking, or was it just that was?
In fact, I think I can more identify.
Is that?